May I invite the chairpersons for this session, Dr. Sanjeev Gulati, Dr. Sukanya Govindan, Dr. Manisha Sahai, and Dr. Jeetu Kurian. And the speaker for this session is Dr. Nivedita Kamath from St. John's, Bangalore, who's going to take us through navigating the journey from CKD to successful transplantations in the pediatric patients.
So good morning, everyone. Welcome to this session. And it's a very important session because, after all, children are not miniature adults. And transplant in children is really challenging, much more than in an adult transplant. Right from the disease, FSGS, CKD, which have their own problems, recurrence, bladder problems, the problems of growth, the problems of family dynamics, the problems of growing up. In addition, transition from, I think, a pediatric nephrologist to an adult nephrologist, from teddy bears to suddenly into an adult world where care is maybe a little bit less personalized, and following transplant problems of immunosuppression, and then marriage and pregnancy, so on and so forth. So I will welcome Dr. Nivedita, one of the best speakers, passionate about pediatric transplant, to introduce us to the topic and take us through it. Over to you, Nivedita.
Thank you, ma'am. Thank you so much for those kind words of introduction and also for putting a huge burden of expectation. I'm very grateful to Dr. Umesh Khanna, sir, for giving me this opportunity to be standing here in this conclave and talking about the journey from pediatric CKD to transplant. And I have taken the liberty to borrow the other half of the sentence from the previous talk, because unfortunately, this is also a road less traveled. So let's see why. And I'll divide my talk into three aspects: the access to transplantation, and when the patient finally reaches you, and okay. Is it better? Yeah. When a patient finally reaches you, what are the medical and surgical issues? I think Manisha ma'am has given a very nice summary, and I'm going to definitely cover some aspects of it. And finally, looking at the outcomes. So we know that preemptive kidney transplant. Kidney transplantation is the best form of renal replacement therapy for a child with kidney failure, and preemptive kidney transplant is definitely the best option. This systematic review and meta-analysis put that in the form of data and showed that there was a significant improvement in graft survival and a significant reduction in acute rejection when a child had the opportunity to get a preemptive kidney transplant as opposed to a non-preemptive. But where do we stand when we are in what we are able to offer to our patients who come with kidney failure? And if we are not able to live up to the standard, what are the challenges? So the first challenge is that children with chronic kidney disease present late to us, and they come with a very high burden of complications. You can see this severely emaciated child with significant bony deformities, and in addition, he had a lot of laboratory abnormalities as well. When we looked at a study from our center of children with CKD stages 2 to 4 and compared it to the CKD database, which is the largest study of chronic kidney disease in children from North America, we found that the median GFR of our population was in the range of CKD stage 3B, whereas in the CKD study, it was in CKD stage 2. Also, you can see that the burden of comorbidities or complications of CKD was several-fold higher than in the CKD study. Among those who present late, about 25% were diagnosed to have kidney disease for the first time when they presented with kidney failure. And among these, about 1/3 of them had presented with life-threatening emergencies requiring urgent initiation of dialysis. And in our study, we found that these children had a high risk of loss to follow-up and mortality. And this is also supported by studies done in similar settings where they found that children presenting with life-threatening emergencies had a high risk of mortality and loss to follow-up, and a systematic review showed that this was more prevalent in low and low-middle income countries as opposed to high-income countries. In our center, we did a study to look at what are these barriers to kidney transplant and why are children not getting transplanted as much as we would like them to. This study looked at all CKD patients registered with us about a couple of years ago, and we found that we had 155 children registered with kidney failure, but a majority of them were either lost to follow-up or died. Among those who continued treatment, only about 30% were transplanted. So even after 2 decades as a referral pediatric transplant center in India, we transplant only about 20% of all children who present with kidney failure. Loss to follow-up is common and results in presumed death in the majority. The barriers, mainly looking at the socio-economic barriers and the logistic barriers, we found that the education level of parents, the occupation, the income, and access in terms of distance and the time taken to reach the hospital were important, significant barriers. Were there any medical barriers? Of course there were, and when we compared our data to the study from the UK, we found that the disease factors, the availability of donors, and the size of the child were what was reported in the UK, and we found similar problems of inadequate access to deceased donor program, unresolved bladder issues, the lack of facilities for a multi-organ transplant, high risk of recurrence, and inadequate expertise for transplanting little children, that is below 10 kgs. Beyond these medical and financial barriers were also barriers of attitude and awareness, denial and poor awareness about chronic kidney disease in children, the primacy of paternal decision-making, difficult choices, negative attitudes about organ donation were all coming in the way of transplanting our children. Is this only in our center or our country? No, this systematic review of outcomes of children diagnosed with kidney failure requiring RRT from sub-Saharan Africa also showed that only about 20% of their patients were transplanted. And you can see that the mortality without dialysis was as high as 95%. Even with dialysis, 1/3 of the children died. Those who were initiated on dialysis, only 50% remained on dialysis after 1 year, and about 1/4 of them were lost to follow-up. And more dismal results were published in the recent study from Nigeria. So the ISN Global Kidney Health Atlas data of 2023 shows that the incidence of kidney transplantation is definitely low in India and countries of similar category. And when we look at the South Asian data, we see that though kidney transplant is available in most of the countries, there is no funding for medications, which makes it a problem for continuing this, and also no official registry to get data on what the challenges are. This survey done by Dr. Sethi from Medanta on looking at the pediatric kidney transplantation services in India found that about 2/3 of the adult and pediatric nephrologists that responded to the survey undertook transplantation in children, but there are only 3 government institutions offering pediatric kidney transplants, saying that most of the centers that offer are in the private sector and are naturally expensive. There are very low rates of preemptive transplants and very few centers undertaking more than 5 transplants in a year. If a patient fortunately manages to overcome all these barriers and lands at your doorstep and is willing to undergo a kidney transplant, what are the steps that we need to take to make sure that we have tackled all the medical and the surgical issues that may arise in the peri and post-transplant period? The most common roadblocks would be the kidney failure complications itself, because we've already discussed how the burden of them is so high in our population. A hostile bladder, which is quite a frequent problem, risk of recurrence, risk of thrombosis, and the need for nephrectomy. Going through a few case scenarios of our own patients, a 10-year-old girl presented with bilateral hypodysplasia has been on CAPD for 6 years. Because of the non-availability of a compatible donor, she's registered for a deceased donor program. She's had multiple admissions for fluid overload, uncontrolled hypertension. We've attempted medical nephrectomy, which did not work, and she has left ventricular dysfunction. So the issues are the complications of kidney failure, uncontrolled hypertension, and cardiovascular complications. Hypertension in children on dialysis with the ABPM or ambulatory blood pressure is found to be close to 100%, left ventricular hypertrophy in 50%, and in our own database we found that about 30% also had left ventricular dysfunction. In addition to the metabolic problems that we all know, the vintage of dialysis, the episodes of fluid overload, intradialytic hypotension, and inflammation are important to tackle. The most important tools for clinical screening and monitoring on a regular basis would be ambulatory blood pressure and echocardiography to look at the left ventricular mass index. And the goal would be to optimize the metabolic parameters and the dialysis-associated parameters to reduce cardiovascular disease-related mortality and morbidity, because it is the most common cause of mortality in children on dialysis and the second most common cause of mortality in children post-transplantation. This girl finally got a deceased donor transplant and is doing well. Coming to a 16-year-old boy who is currently 16 years, but he was referred to us after he was underwent a fulguration for a posterior urethral valve that was diagnosed at the age of 6 years. When he came to us, he had severe bony deformities, hypotonia, he was wheelchair bound. His bladder had showed a small capacity, high pressure with a high-grade reflux. He underwent an augmentation cystoplasty and was on intermittent catheterization. CAPD for 4 years, shifted to hemodialysis because of recurrent peritonitis, and he's on hemodialysis for 5 years. Finally, the family has come around considering transplant, but you can see that there are multiple issues here. Even after the augmentation cystoplasty in the voiding cystourethrogram, you can notice that there is still a bilateral high-grade reflux. So in addition to the severe complications of kidney failure itself with the metabolic bone disease and the debilitating deformity, which may be corrected partially post-transplantation, and the impact that that would have on his quality of life. He's undergone multiple abdominal surgeries, so risk of adhesions, risk of difficulty during the transplant surgery. But what we will focus on is the risk of urinary tract infections post-transplant because of the abnormal bladder and the need for lifelong CIC in addition to other lifelong immunosuppression and medications. If we look at the Napretics data, among the 5 most common causes, 3 of them, that is Charcot, obstructive uropathy, and reflux nephropathy, could be associated with issues with the bladder. So the bladder cannot be overlooked in a child prior to transplant. This is data from our center which looked at the outcomes of children with lower urinary tract dysfunction looked at their graft and patient survival post-transplant and compared it to those who had a normal bladder. And we found that definitely there was a reduced graft survival as well as patient survival, which was statistically significant. And similar data has been reported from large databases, the ANS data, the Argentina database, as well as, comparing to our own. Now, lower urinary tract dysfunction can has damaged the native kidney and can damage the graft by recurrent UTIs as well as the high pressures in the bladder itself. Simple tools that we need to use for every child would be a voiding diary, looking at the ultrasound, and the voiding cystourethrogram in those who have a higher risk. But definitely pre-transplant, we would like to do a urodynamic study to look at what is the pressure during the storage of urine, what is the pressure during voiding, what is the capacity of the bladder, and is there a detrusor sphincter dyssynergia, which puts this patient at additional risk. The goal is to provide a bladder that stores at low pressure, empties completely with social continence. And the line of medications, the first line would be the use of anticholinergics. The clean intermittent catheterization is a simple but not a very easy to perform, in the sense that it is required lifelong. It has to be done every 3 hours. So it is something that the patient needs to be trained, and we should do it before transplant itself. Bladder augmentation is required in those who have the worst bladders, and though there is a controversy of whether it should be done pre or post-transplant, in our center we routinely do it pre-transplant, ensure the initiation of clean intermittent catheterization, and ensure compliance to CIC before we venture into transplant, because this can be one of the very important causes of a subsequent risk of UTIs as well as graft loss. Coming to our next patient, 3.5-year-old boy, 12 kgs, primary steroid-resistant nephrotic syndrome, who was also CNI resistant, but surprisingly was genetic negative. Biopsy showed the expected FSGS. The parents wanted a preemptive transplant, but he rapidly progressed to kidney failure and was initiated on PD. He's been on PD. He got transplanted about 2 weeks ago. Pre-transplant had massive proteinuria, so the issues in him are the high risk of recurrence, the risk of thrombosis, and his low body size. Recurrent disease is one of the important causes of graft loss in pediatric transplant, and the most common conditions, of course, are FSGS, which is the second most common cause of kidney failure in children requiring transplant. In addition, atypical HUS, typically the genetic mutations of factor H and others. Primary hyperoxaluria, of course, we know has a almost 100% risk of recurrence, and dense deposit disease. What you may note is also that not only is recurrence high in these conditions, but also the graft loss that is attributable to the recurrence. So in children with FSGS, which is probably the most common thing that you will see with recurrence, is the need for a risk stratification prior to transplant. A genetic evaluation is a must. Donor selection based on the risk stratification. Estimation of proteinuria at baseline to have to know what is it that would raise a red flag about recurrence post-transplant. Post-transplant, they need intensive monitoring, doing urine protein creatinine ratios on a daily basis for the first 4 weeks, because that is the period of maximum risk. Plasma exchange and rituximab as saviors here. This boy had a recurrence and is on plasma exchange currently. Thrombosis is children less than 2 years, donors less than 5 years, a donor-recipient size disparity, prolonged cold ischemia time, and massive proteinuria are the risk factors. It is the second most common cause of immediate graft loss. Coagulation profile and a detailed evaluation for any coagulation disorders, attempting to reduce the proteinuria by maybe a unilateral nephrectomy, and Doppler imaging as early as in the intra-op period itself. We could use prophylactic postoperative anticoagulation to prevent thrombosis, but they require intensive monitoring. Low body weight or size is reported in Western literature mainly as infants and toddlers who present with kidney failure, but in our scenario, it also includes older children who are severely malnourished. The most common indications for transplant here would be congenital nephrotic syndrome, CACUT, ARPKD, and neonatal cortical necrosis. The patient-related challenges are optimizing growth and nutrition. They wouldn't have reached the age to receive all the vaccines. They are usually CMV, EBV, naive, putting them at a risk of these infections. Syrup formulations are not available for some of the immunosuppressants, so you need to look at alternatives. From the surgical aspects, having adequate space, vessel size discrepancy, intraoperative blood pressure monitoring, and from the kidney disease, massive proteinuria, risk of thrombosis, and need for nephrectomy. The outcomes, however, from Western literature have been very encouraging. A 10-year-old girl, ARPKD, severe hypertension, chronic liver disease with complications. So in addition to extrarenal complications that we need to handle, the need for a liver, kidney, or multi-organ transplant and native nephrectomy. Liver kidney transplant, of course, the standard is the primary hyperoxaluria, but also autosomal recessive polycystic kidney disease forms another important group. Native nephrectomy may be required in children who have significant proteinuria, a non-functioning kidney with high stone burden or recurrent UTIs, intractable hypertension, polycystic kidney disease, a risk of future malignancies, or just to create space to accommodate the adult big kidney into the little abdomen. Though there is a controversy about the timing of nephrectomy, and different centers have their own protocols, we usually prefer to do a pre-transplant nephrectomy or an intra-op nephrectomy. Infections and vaccinations, so live vaccines should be given 4 weeks prior to transplant and are contraindicated post-transplant. The interval between the pre-transplant immunosuppression for the glomerular disease needs to be kept in mind, and monitoring of titers and booster doses whenever required in the post-transplant period. Some perioperative, mainly anesthesia issues we should be on the watch out for. Look at cardiovascular function, associated comorbidities, especially the upper respiratory tract, and lung issues. Native output, because children can be anuric or polyuric, and that may come in the way of fluid management. Maintaining maps of at least 70 millimeters of mercury to and allow perfusion to the adult kidney. You may need to use vasopressors to do this, use of bicarbonate and blood transfusions to maintain hemodynamic status, intensive monitoring, need of mechanical ventilation post-transplant, and pain management. Though adherence is typically a post-transplant issue, one needs to identify those at high risk, like adolescents and other socioeconomic or therapy-related factors, and address them in advance. The outcomes of pediatric transplant have been very promising. This is a little older data from the Napretics database, but even more recent data shows that the 5-year survival for deceased and living donor transplant is somewhere between 95 to 97%, and the 10-year is 85 to 90%. The most important causes of mortality are infections and cardiovascular complications. The most important causes of graft failure are chronic rejection, acute rejection, vascular thrombosis, and recurrence, and death with a functioning graft has been reported in 10%. Transplanting a child is a huge team effort, and we have been very fortunate to have a team of dedicated doctors, nurses, and the transplant team, but also support from the ISN through the Sister Transplant Center program, which has definitely helped us give our donors and recipients a better experience with transplant, but we do acknowledge that there are miles to go before we can rest. Thank you.
So I think that was an excellent overview, Nivedita, and as far as pediatric transplant is concerned, I mean, this remains the gold standard of therapy, but years back when we did our study, our penetration rate was about 14%. This was in 1999 when we prospectively looked at over a period of year, and you have reported 20%. So obviously a lot more needs to be done. And children often suffer from a double whammy. You know, first and foremost is the attitude. The first point of contact is a pediatrician, and sometimes even a nephrologist, who discourage transplant in children. Although what they forget is that the long-term outcomes are actually better than adults. The survivals are better than adults. And the second major issue which I have found is the access is limited by financial constraint, because children are not, they don't have any insurance or from either the employer, or none of them are medically insured. So it's an out-of-pocket expense for the family. And that, I think, is one of the major barriers. In the same family, we have found that a 70-year-old has had no problem getting a transplant, whereas 11-year child, then come the medical and surgical challenges. So I think there's a lot more needs to be done. I think we need to highlight the success stories so that we can change the attitudes.
Sukanya? Yeah.
So, great talk. Just wanted to know about preemptive transplant. We know that's the way to go, but in India, I mean, what's your experience, preemptive versus when they really need a transplant? That's question number one. And do you feel the gender disparity exists in pediatric transplant as well? Have you seen that in your practice? And I mean, answer these questions first.
Thank you, ma'am. Thank you, sir, for your comments, and I think you have brought out very important points that we see on a day-to-day basis. Answering ma'am's questions, I think the preemptive transplant in our center, we have done very few preemptive transplants, and like I said, most of our patients present with kidney failure, I mean, at least a good 25-30% present for the first time diagnosed to have a kidney failure when they come with fluid overload, severe acidosis, requiring ICU admissions. So there the whole opportunity is already lost. When we do see them in CKD, or when we are initiating dialysis, or before we want to, when they are in that kidney failure, stage 4, stage 5, they are going towards, a lot of other barriers that we spoke about, that parents are not willing, they have negative attitudes, they talk to hundreds of people who give them what is the long-term outcome, is it really worth spending so much time? The child will have to be on lifelong immunosuppression. And lifelong means completely different for a child as compared to an adult. For an adult, it may be another 20 years, but for a child, one thinks that it may be for the next 50 to 60 years. So all these are the barriers that we face. So even in our center, though we try and push and try and counsel our patients while they are in stage 4, preemptive transplant rate has been very low, and that is also noted in the study by Dr. Siddharth from other centers in India. Regarding gender disparity, definitely there is a gender disparity even in children. It may not be as obvious, or the reasons may not be as obvious, but both in terms of the donor and the recipient. Like if we look at our data, majority of our donors are mothers, very few fathers, and very few other relatives who come, because ours is predominantly a living related donor transplant. From the recipient point of view, the people who are lost to follow-up are mostly girls as compared to the boys. So for the boys, though it doesn't come out, obviously there is a sense we can get that if it is one male child or one male child among several female children, definitely the family will go all out to try and do their best. But that may not be so for the female children. So definitely we see that in our practice.
Nivedita, excellent talk.
Thank you.
And I have a question for you that in our state, dialysis, access to dialysis is improved tremendously because of the availability of schemes and free dialysis for patients. And a good number of centers do have pediatric dialysis. But over the years, and this is a trend that is more likely to increase because the dialysis is free. Many patients are comfortable on dialysis.
Yes,
and
absolutely.
that sort of puts transplant at the very back in the list of priorities that the family has because dialysis is taken care of.
Yes.
And more and more we see patients starting dialysis as a kid and going on to become young adults on dialysis. So how much of that do you see in your region, in your state? And also to the members here, what do you think as a community that we should be doing to address this? Because there are certain centers, say in Singapore or anywhere, where the dialysis program is funded for regular patients only for 2 years.
Yes.
And after that, they have to get means to transplant. So, of course, we also have as a community to produce the data and take it to health policy decision makers. But what are the suggestions from the chairs also?
Yeah, thank you. Thank you for the comments and for your question. And that is really a very important question.
So
and we do see that
because the last lecture we may not be able to take because Dr. I allowed Vivek Jha.
I think so. Okay. So what we do see this happen very often in the sense that
Probably more than.
so when patients come when a child comes to and is admitted in the ICU with a life-threatening emergency, the parents want to do everything because they know if they don't, the child will not survive. So at that time, they are ready to pool resources. Probably people are also, like we also are able to provide them with some financial support. Organizations are ready to support it. So, it is easier to manage that situation. But once they are started is eating well, to them all seems okay and they get into the routine of doing dialysis. So we have internally discussed this point several times that should we at some point in time, obviously we can't do it when the patient comes in very sick, but at some point in time start telling the family that if you're not considering transplant, then dialysis is of no use. But since most of our patients are spending for dialysis from their pocket, if they want dialysis, we have to do dialysis. This is not funded by an insurance or by the state program. So in that sense, there is no way that we have control on or we can push them towards transplant. So that is one thing that we have noticed. And we've also tried the other way around, interestingly, that we have said that we will support transplant. The major chunk of expense comes during the transplant surgery, right? So we will find, and donors are ready to support transplant. They are not ready to support chronic dialysis. They are ready to support AKI. They are ready to support a child in the ICU. They are ready to support transplant. They are not ready to support chronic dialysis. So we have said we can give you financial support for the transplant. You have to bear the cost of immunosuppression thereafter. Even then we have found that there is a lot of lag. So I think the problem is not just financial, but also the attitudes, not just of our patients, but of the community that is influencing them, of, like sir rightly mentioned, we have had people come back and say, no, but our pediatrician said, no use, just let the child, be on dialysis or just leave it. It's not really worth spending so much time, energy and effort on this child. So I think it's attitudes also.
So just last question, and can I step back and ask a question that as adult nephrologist, early career nephrologist, when we see, even in spite of being trained in SGPG, one of the fair institutes in India, I feel very jittery in the middle of the night when a 3-year-old or a 4-year-old child comes to me with probably an AKI or CKD. So my question is that, from the pediatric nephrology group, what can we do with respect to as a society to incorporate some kind of a basic training during or after the course, so that we as early career nephrologists are little more equipped, that we don't feel jittery with respect to the small numbers of the catheter, the blood flow volume, or suddenly when the child develops a complication, what next to do. I have been fortunate that I'm from St. John's, and I had the in the middle of the night, I call up Dr. Nivedita or Dr. Alpana, and they come up with suggestion, and I'm courageous enough. But we don't have the liberty, everybody doesn't have the liberty, and we don't have a pediatric nephrologist at our call or at a referral distance. So as a society, as Indian Society of Nephrology and Pediatric Nephrology, I think we should come forward with a program, probably a 1-month program or a 6-month program, in which an early career nephrologist can go in and get ourselves trained so that we don't feel jittery. We don't want to be an expert in it, but we don't feel jittery to start an order and put forward. And my second question is that, should we give a priority for the pediatric recipients with respect to the disease donor? And in Karnataka, do we have a priority listing for the pediatric patients to be taken up?
Yeah,
Short.
yes. Answering the first question, I think we've had, of late in the last few years, more and more adult nephrology trainees coming to our institution for a 1-month observership, like an external posting. Like when we do our pediatric nephrology training, we go to the adult unit, and so the vice versa happens. And now we have had several trainees coming from different centers, mainly from Tamil Nadu. We could get feedback from them to see how much it has helped them. A few of you here also have come to our institute. So I think that sort of gives you a sensitization to this thing. But of course, procedures and all that may be difficult, but at least you know what to do or how to calculate per kg doses or something of that sort. So some basic information. So that may be a good idea to incorporate in the nephrology training for adult nephrologists. Given your, sorry, what was your second question? The disease donor, absolutely. I think they should be a priority for pediatric transplants. Unfortunately, currently in Karnataka, it's not, there's no extra weightage that is given to children. It was given before. Currently, it is not, but I think that definitely should be the way forward. Thank you.
I think a lot of pediatric nephrology has been taught by Nivedita. The rest of it will have to be learned by ourselves later on. Thanks so much.